Welcome back to Doctors and Litigation, the L Word. This is Season 2, Episode 11. Hey everybody, it's Geeta, and today we are going to talk with an expert witness. My guest is Dr. Stephen Cohen, longtime general and colorectal surgeon who has been doing expert witness work since the 1990s, and he has a wealth of experience that he would like to share with you. Now, if you haven't listened to the episodes on deposition and the episodes on expert witnesses in the first season, I would suggest that you do that first. But today, Dr. Cohen is going to highlight a few key mistakes that he has seen physician defendants make over the years. And I will warn you ahead of time that there are legal outcomes that you'll hear about that will make you want to pull your hair out and scream. So expect that ahead of time. But also, this is a good time to reiterate the point that legal outcomes should never be used as a proxy for how good someone's medical care was. That's such an important point to get across, that in medical negligence cases, you cannot infer anything about the doctor's care from the jury's decision because juries don't understand medicine. And that will become very apparent as you listen to the outcomes of these cases. But I want to say something as an aside right now. If you are a physician on a state licensure board, I am talking to you. I'm going to say it one more time. You can never, ever use the outcome of a jury trial alone to decide whether or not a doctor's care was negligent or whether or not to discipline that doctor or impact their license in any way. I'm going to talk about this in another podcast, but yes, there are states out there that are either doing this or considering doing this. And if you live in a state where that happens, please send someone on the board this podcast, because if they are making these judgments based on jury verdicts alone, they are going to get it wrong. And that's not okay. Okay, let's get into this podcast now. I think you'll learn a lot. And then after that, I will see you in 2025 when I will have a really big announcement for you, and I cannot wait to tell you about it. But let's get to our conversation with Dr. Stephen Cohen. Dr. Stephen Cohen, thank you so much for coming to talk to us on the podcast today.
It's my pleasure. Happy to be here.
Okay, so you are a general and colorectal surgeon with over 30 years of experience. And the real reason that you're here today to talk to us about litigation is because of your experience as an expert witness for many years. But first, tell us about your professional life. What do you do as a doctor?
As you stated, I'm a general and a colorectal surgeon. Now been in practice for over 30 years, coming up on year 31. The first 23 years, I was actually in private practice in Atlanta with a very large group. We had 9 doctors, 7 offices, 50 employees. But the last 7 years, I've really been in academics, teaching, training, educating both medical students and residents at the Richmond, Virginia VA Medical Center.
So tell us about your career as an expert witness. You know that, there are 2 hours of podcast about expert witnesses, and I do encourage everybody to go back and listen to those, as well as the episode on deposition. These are all in season 1. And it is very true that I have some ire for expert witnesses that don't do right by people, but I know your reputation, and I thought it would be really helpful to have you come and talk about it. So tell us about your career as an expert witness.
Yeah, so we can certainly unpackage all of that because I've been yelled at, screamed at by not only patients, but also other physicians. But it really started back when I was a resident. I was asked to come into the courtroom. I was on the trauma rotation in the emergency room in Boston, and I got subpoenaed to come and testify to a jury that what I saw on the bed was actually brain matter from a gunshot wound. And I thought that was really cool. So, medicine is very different than legal world. I feel much more comfortable, at least back then, in an operating room than I ever did in a courtroom. It's not our world, and it's a very different world, as you know. But it was my first year in practice in 1994 where my senior partner asked me to review a case. He said, look, I'm conflicted. You just started in practice. Are you willing to review a case? I didn't even know what that was. I didn't know you get paid for it. I was very naive in the beginning, and I did it the first time. I enjoyed it, and it's kind of grown from there in different aspects.
Now you've reviewed scores and scores of cases, many, many, many depositions. And the reason that I asked you here today was to come and talk about some common errors that you see defendants making within their cases or within their deposition.
So at this point, I do about 50% plaintiff work and 50% defense work, and I enjoy both. Well, first of all, the only way the system can actually function is you have to have expert witness to explain to juries, to explain to the court, to explain to attorneys what we do every day as being a doctor, because they don't know. So that's thing one. Thing number two, I also feel that it makes me a smarter doctor because I have to stay relevant. I have to continue to practice in the field that I'm opining on. And one of the biggest things that I see is that if and when we all get sued, and I've been sued 5 times, so I know what it's like to be sued. I know what it's like to be emotionally involved in something that I felt I did nothing wrong. And I get it because I was surprised as anybody when I was served in my office from a uniformed police officer, in front of 30 of my patients. That didn't feel good. I'm not a criminal. Seriously? And then the second time was in my house with my kids in the house and my wife, and a police car came driving up. It's a very bad feeling.
Yeah, we've talked about that. And if you haven't listened to the episode about getting served and the different ways that that could happen, I also encourage you to go back and listen to that. But, it's different depending on different jurisdictions. But yeah, that's pretty dramatic when an officer of the court or a police officer or a sheriff comes to serve you in person. And sometimes they do time it for maximal impact. But let me ask you a question. Did you have any expert witnesses that testified you or opined on those cases that you disagreed with?
Yes, absolutely. We can talk about that a little bit. I'm going to go back and answer your first question, though. The biggest mistake that I see physicians, and I was the same way, the biggest mistake I see is not really understanding the way attorneys will spin the discussion and frame the discussion to make you answer the way they want to. And I know that seems kind of confusing, but if A equals B and B equals C, A doesn't always equal C, right? So, there's a lot of nuances in medicine, and the best person to know what's going on is the doctor that was standing at the bedside, because a lot of these cases happen a year or 2 years down the line, right?
Yeah.
I think the biggest mistake is the fear of the unknown. It's like anything else. It's like having surgery for the first time. It's diving off a high dive for the first time, right? You don't know. Your first date, when you're a teenager, you don't know. It's fear of the unknown. And I think your service and what you do, giving defendants or physicians that are being sued the information and taking the emotion out of it. I wish you were around during my first deposition 25 years ago because I was scared to death, right? I felt like I did nothing wrong. So out of my 5 cases, 2 of them were dropped, 3 of them settled. In the 2 dropped cases, they did not have an expert that say I fell below the standard of care, probably one of the reasons they dropped. But even though I reviewed a bunch of cases, when I first got sued, I was an emotional wreck, as most people are. And having somebody who's gone through it that can take the emotion out of it and say, look, these are the questions you're going to get asked. Don't fall into the trap, which is easier said than done, of arguing with the attorney, acting like you're smarter than the attorney. Because remember, they do their research as well, and they have an expert, or they've talked to a physician. So it's not like you can just be arrogant and think, well, they're just the dumb attorney. They're seasoned going into this. I think the service that you do to help guide them is invaluable.
Thank you. I appreciate that. Let us talk about some specifics. Can you give us some examples of mistakes that you've seen and sort of illustrate how people fall into some of these traps? Like when you talked about A equals B, not necessarily equaling C, but they will try to lead you down that path. Do you have any specifics for us?
I do. So in case number 1, there was a colorectal surgeon that was presented a patient with an anal lesion. That was probably benign, but it was a, 2 centimeter at the anal verge, umbilicated lesion. No biopsy was done. It was a growing, painful, bleeding lesion. Well, for a colorectal surgeon, that's easy. You have something abnormal growing on your butt, we're cutting that out. There's not a lot of rocket science for that. The problem was this patient was on a blood thinner. Okay, he was on Coumadin. What is standard of care for a patient if you're going to operate on an area that has a high potential for bleeding? Is you take them off the Coumadin and you take them off for 5 days. That's what the surgeon did. The INR the morning of the surgery was normal. The patient underwent surgery. The patient went to the recovery room. The patient was started on the Coumadin that night when he went home. However, in the morning, he had a stroke, massive stroke that left him with significant deficits. The claim was that he should not have taken him off the Coumadin because, and this is kind of weird, what the attorney said and what they hired someone to say on the plaintiff's side was that the opinion of the plaintiff's expert was you did not need to take the patient off the Coumadin. The risk of a stroke we know is going to be probably 1 to 3%. And that part of the body, based on a reasonable degree of medical certainty and probability, would not have bled. Therefore, it was a breach in the standard of care to take the patient off the Coumadin.
Oh, my goodness.
And I'm thinking, you've got to be kidding me. I mean, that's what I would have done. That's standard of care. Because again, a physician or a surgeon in this particular case hypothetically does not take them off the Coumadin, and now they have a bleeding episode, it can be a problem. And that area can bleed. So what happened? And why am I making an example of this case? Well, I was on the defense side. I said he met the standard of care. This is a bad outcome. And what I say all the time is outcome is irrelevant in standard of care. You don't know the outcome, but if your judgment is within the standard of care, you can have a bad outcome. Unfortunately, most medical malpractice cases are bad outcome. They're not malpractice. So during this particular colorectal surgeon's deposition, he went through, the question and answer, and why did you do it? And did you give the patient an option? But I read, doctor, that these things don't bleed. Are you disputing the literature? And he pulled out some articles of how low the bleeding rate was. The plaintiff attorney really was egging him on. So one of the last questions on the deposition was, and this is where he got himself in trouble. The last question in the deposition was, so doctor, looking backwards, if you knew this patient would have had a stroke off the Coumadin, would you have left him on? Or in other words, would you have done something different in hindsight? And the surgeon said, absolutely, I would have. No, if I knew he was going to have a stroke, I would have kept him on the Coumadin.
Okay. That seems like a reasonable answer on its face. Okay. So I understand why he answered the way he did, because if he had had a crystal ball and knew that was going to happen, then he would probably have made a different choice. Tell us what happened with this case, and then let's talk about maybe how we should think about that question.
Yeah. So what happened was, my mistake was I told the defense attorney, this is an easy one. That was not the right thing to say. Of course, I just said it to the defense attorney. So this went to trial. I explained everything. I got off the stand. I drew pictures. I explained everything. Not a problem at all. Unfortunately, the jury found in favor of the patient. And why was that? Because the jury foreman told the attorneys, because the surgeon said he would have done something different, there must have been a breach in the standard of care. So on its face, hypothetically, however, again, let's go back to outcome is irrelevant in standard of care. If I'm on the plaintiff side, I get yelled at by defense attorneys that, Dr. Cohen, you're looking at this case in hindsight. You knew the answer before you started the review. And my answer to that is, but that's not what my opinion is based on. My opinion is based on post-op day one. I'm standing at the patient's bedside. I'm looking at what's documented history and physical. I'm looking at the labs that they say. I'm putting myself in the patient of the physician and what is standard of care. Well, if that's the case, on the defense side, it's the same thing. The next 10 patients on Coumadin who need surgery that have a potential for bleeding, you're still going to do the same thing. A much better answer would have been, no, because I met the standard of care in taking my patient off Coumadin, not knowing the outcome, I would not have done anything different.
That's the key. He's trying to trick you by saying, now that you know the outcome, would you have done something different? I can't answer that question truthfully because that's not a possibility. I can only say that in that moment, I did what I knew to be the right thing in that circumstance.
Correct. But again, you're emotionally involved in the case and it's hard to think rationally. And I get that because I've been in those depositions or I've been in the courtroom. And once your emotions get you, it's like getting in a fight with my wife. Don't let your emotions get ahead of you. But it's a lot easier said than done.
It is.
But having a physician who has been through it, who knows the questions that are coming, knows how they're going to trick you, understanding it, you're much more apt to answer correctly so you don't trip up. And again, in that particular scenario, that was the only reason the jury gave that they actually found for the plaintiff and not for the doctor, which was disheartening.
Yes. And as we've talked about before on this podcast, this is all an art to them. They've learned how to exploit your emotions. This is business for them, and they've been trained in these techniques. And it's not unusual for them to do things like, I was just working with somebody who they were going through the autopsy report and asking the physician to surmise what degree of suffering that person had from these conditions, which is, it's kind of absurd. The only way that you can answer something like that is to say, like, I wasn't there. I don't know. What are you going to say? Like, I know he suffered X much. The problem with the hypothetical questions are that you can't answer them. You cannot answer them. There's no truthful way to answer those hypotheticals. And so it gets very, very difficult. And there is some skill involved, I think, in being able to notice what the question is that's being asked you, what they want you to do, and that you don't have to answer it the way that they've laid that question out.
Correct. So for another example, and this is a big one, is, and I tell the residents this all the time, do not ever fight or argue with your colleagues that you consult or working together with a patient in the chart.
Yes, we call this the circular firing squad.
Oh my goodness. So there was another case, and this is another crazy case. So this was a gentleman years ago who went out to eat Mexican food, and 3 hours later, nausea, vomiting, and abdominal pain. Presents to the emergency room, of course, at midnight with, a tender abdomen, no fever, no white count, stone cold, normal labs. No left shift, no lactic acidosis, no renal failure. They give him a GI cocktail, sounded like a gastroenteritis or food poisoning or something that he got, and he improved. Now, when they gave him the GI cocktail and he improved, they ordered, of course, an abdominal pelvic CT scan. The CT scan was read as there is some minimal amount of air in the liver. The way it was worded, I can't tell if it's biliary or it's portal venous gas. Clinical correlation advised. The secondary assessment 2 hours later after the GI cocktail, patient says, I feel better. I want to go home. Abdomen, no more tenderness, no more repeat labs because everything was normal. The recommendation, this was a Thursday night, was why don't you follow up tomorrow? We're going to order you an outpatient ultrasound just to see where this air is because we want to follow up with that, and then follow up with your doctor.
Now, just for people who don't practice surgery, just knowing forward the implication of air in that area.
Yeah, so air in the liver can be an ominous sign, and the portal venous gas usually, or the most likely cause of that will be a mesenteric ischemia or dead bowel. So that's an ominous sign. Now, you can have air in the biliary system from a lot of different causes. That's completely benign. So now the radiologist can't tell, but you have a patient who is nothing wrong in his laboratory findings, has a good story for food poisoning, responded to oral GI cocktail, wants to go home, and has follow-up the next day. This is a Thursday night. He does not follow up. And on Sunday morning, he wakes up in severe abdominal pain, fever, comes back to the emergency room. Now he's hypotensive, acidotic, renal failure, peritonitis, CAT scan shows dead bowel. He goes to the operating room, loses about 50% of his small bowel, survives, believe it or not. The claim was you missed it the first time around. And I'm looking at this chart thinking, do you know how many patients I've seen like this that I've sent home?
Of course.
Again, it's what is the standard of care in somebody who presented the way I described it is you can go home and you have follow-up. Well, the problem is that when the patient was there the second time and, the surgeon who was so the surgeon was called about this. That's where I got involved. I was opining, defending the surgeon who did not examine the patient, but did get the call from the emergency room. Now you have a doctor-patient relationship because you're on call. And he got the call, heard the story, said, fine, we'll follow him up tomorrow, give him all the information. The same surgeon who operated and the radiologist were fighting in the chart who missed what and why didn't somebody tell me, right? So that was the problem. So now it goes to trial, believe it or not. They didn't want to settle. The surgeon said, I did nothing wrong. The radiologist did not get sued, but there was some fighting in the chart about the radiologist should have called me directly. The radiologist missed the portal venous gas. I would have operated sooner. Right. Now it goes to a plaintiff attorney. That's perfect. If you fight amongst each other, you may as well just write the check to the attorney because they're going to get it.
Someone's going to be writing a check, right? Clearly, there has been some sort of breach, is what they'll argue.
Right. Of course, because you're fighting amongst each other. And again, you can disagree and you can have a difference of opinion, but the way you document it can definitely get you in trouble. And this was not very nice commentary documented in the chart. And that's when I first read the chart, I said, you're going to have a problem with this because what's written, if I'm a jury, my goodness. So what happened was the radiologist did not get sued. So the radiologist became the plaintiff expert against the surgeon.
Oh, boy.
So what the radiologist said in trial to the jury, and he wasn't getting sued, it's like an immunity. The radiologist said, what I wrote in the chart was not correct. I made a mistake. He admitted making a mistake. It should have been portal venous gas. And then the assumption was, well, if it was portal venous gas, the surgeon already said he would have come in and operated or put a scope in to make sure it's not dead bowel. So the jury found, again, for the plaintiff. And so that's another big mistake of fighting with each other.
They found for the plaintiff, okay, let's unpack that for a second. The radiologist states that it was his fault, essentially.
Correct.
He is not the defendant. So they find the actual defendant, who is the surgeon, they find him liable.
Correct.
Even though it's been clear that the decision-making fell upon the radiology report.
Correct.
So that doesn't seem fair.
That doesn't seem fair. That is correct. And I think I remember walking into the trial and I hadn't met the surgeon. I said, we got this, no problem. I was very confident that I could explain it to the jury that, it's not fair to rely on somebody changing an x-ray report. This was 4 years after the event when the surgeon, armed with the information that he had that was given by the emergency room doctor, which was all true facts, that more likely than not, the problem is it was hard for me to convince the jury, where did that error come from? He probably had some ischemic event, but it resolved. And unfortunately, because he had other medical problems, the disease process progressed.
Right. So I think that, the message to take out of that is that two things. One, when I start working with people, I often say that if you come into this process expecting fairness, you will be disappointed. There is a lot that happens in this that's not fair, and you want to rail against the reality of that, but you have to accept it and then learn how to strategize within it. There are a million things in life that aren't fair. This is one of them. But learning how to operate in the environment and, when you feel clearly that you were right, learning how not to shoot yourself in the foot in the process is really, really important. And the other thing is that juries, they don't understand so much of what we're telling them. They just need a really, really, really clear story. And they get the feeling like that chart argument was probably put way up on the wall. Like you could see people's notes and their words. And then all they get is the sense of like, well, clearly somebody messed up and this person is the defendant. So let's give the plaintiff the money that they deserve.
And to really echo what you said, it's if and when you're going to trial, it is a complete crapshoot because, and I hate to say this, the truth doesn't really matter in a court of law. It really doesn't. I've seen it go both ways.
I think what does matter is who can tell the simpler and more convincing story. That is what it comes down to. Who can tell a story that the jury can understand? And this is where doctors get into the weeds a lot as we're explaining all the nuance and the medicine and this and that. But what they need to hear is the story of why you did the right thing. That's what they need.
So a 50-year-old lady comes to her gynecologist because she wants to have her 10-year-old IUD removed. She is completely asymptomatic. Well, she was 50. She had not had a screening colonoscopy, so the primary care doctor sent her to see the gastroenterologist to do a colonoscopy, which was done 4 weeks later. And then she was also sent to the primary care center to a gynecologist to remove the IUD. So asymptomatic, she gets her colonoscopy, which is stone cold normal. A month later, she shows up in the gynecologist's office. She already had a normal colonoscopy. He sees the string of an IUD. He tries to take out the IUD. It's stuck. He can't do it. She's having pain. He says, you know what? I need to do this in the surgery center. We'll give you some sedation, but we'll take care of it. You're wondering how I got involved in this case. 4 weeks later, she's in the outpatient surgery center, MAC anesthesia, lithotomy position. It's a little bit difficult to come out, he describes, but he's able to pull it out one limb at a time. The left limb is more stuck than the other one, but he gets it out intact, recovers, meets discharge criteria, goes home. 24 hours later, severe abdominal pain, sepsis. She goes to emergency room now because it was an outpatient surgery center. CAT scan shows a perforated colon. She goes to the operating room, a small hole with very little fecal contamination, but a hole that was seen. The surgeon does a colectomy and a colostomy. She does fine. 3 months later, gets her colostomy closed, does well, and a year later, sues the gynecologist for putting a hole in her colon from an IUD. I was asked to talk about causation. I'm not a gynecologist. I can't opine on standard of care treatment of IUD. Dr. Cohen has never pulled out an IUD before, thank goodness. But the claim, and they hired a plaintiff gynecologist to say that based on the fact that it was a difficult IUD to take out, the gynecologist should have done a CAT scan. Listen to this theory. The CAT scan would have shown that there was enough inflammation or it was stuck to the colon that before the gynecologist would have operated, they would have asked a general surgeon to put a laparoscope in. So while he's taking out the IUD, if there's a hole, they would close it.
This is an IUD where you can see the strings.
Yes.
Are like, okay, it's living where it's supposed to live.
Yes.
Wow.
Oh, and he does an ultrasound too. So in the office, he does an ultrasound that shows the IUDs in the uterus, and he can see the string. He just couldn't get it out.
Oh, for goodness sakes.
But remember, the claim is that if he did a CAT scan, this is one of the things that you can't make this up. I heard this case. I went, what are you talking about? If the IUD is stuck, he should have done a CAT scan. It would have shown a problem. He would have asked a general surgeon to put a laparoscope in before he does the procedure. And if there's a hole, he closes it right away, no colostomy. Talking about keeping it simple. So there was a few things, this seemed like a very nice jury. I was drawing pictures of the colon. I said a couple of things. I said, thing number one, I have never heard of this complication before. So, it's one of the copper IUDs. One of the limb was probably through most of the uteral wall, which caused an inflammatory response. So I explained that. But I explained, here's a lady who's asymptomatic. And oh, by the way, remember she had a colonoscopy. So I can tell you that limb of this IUD, and I drew a picture for the jury, the limb was not in the colon. Otherwise, the GI doctor would have seen it, right? So we know it wasn't in the colon. Thing number one. Thing number two, she had no symptoms at all. If I have this patient tomorrow and my GYN doctor asks me for my opinion, we look at risks-benefit ratio of doing surgery. I would not subject somebody to a procedure that's not indicated. If the IUD comes out, which it did, the chance of this happening is probably less than the chance of me having an injury from me just doing the surgery of something she didn't need. And the other important point I tried to explain to the jury is The surgeon who did the colostomy did not need to do that. I said, let's look at his operative note. He had a couple of drops of purulent material. There was no stool. She had tenderness, but she wasn't hypotensive. She wasn't in septic shock. I went through all that with them, simple as I could. I said, one option the surgeon could have done was simply close the hole. It wasn't a diseased colon. The colon was just the innocent bystander, irrigated it out, and that's it. She didn't need the colostomy because the big claim was she had to suffer because of the colostomy. I explained it to everybody. There was a GYN expert on the defense side, same thing. It's not standard of care to call the surgeon if she's not having symptoms. That's ridiculous. The jury found for the patient against the gynecologist. Why? Because the jury said, we felt bad the patient had to have a colostomy. And I'm thinking, I spent an hour telling you the patient didn't need a colostomy, as nice as I could be. So again, the truth doesn't matter. It's very difficult to explain the nuances and the medicine to juries, and it's not their fault. They don't have medical background. They didn't go to medical school, and you never know what they're thinking. Some of them may have been harmed even worse by a physician or their relatives been hurt, and they want to make a statement, and you don't know that.
Well, I have a couple of points I want to make. One is that even though we're telling these stories just to sort of illustrate points about how the medicine is beside the point, I do want to say that most often the physician does prevail in court. Usually the physician or the clinician wins at trial when you go to trial, because you go to trial because people are confident in your care most of the time. And most of the time you're going to win. Sometimes you're going to lose. And the point I want to make about that is that usually it's not about your care when you lose.
Right, exactly.
Usually it's not about your care. Usually it's about some other thing. And the second thing is, it really is the job of your defense attorney to make the jury understand that this is not a decision that is supposed to be made. The way they're supposed to think about this is not in terms of their sympathy for the plaintiff and their suffering, because they will often come back to this like, well, they need money and someone ought to pay the money, and it's just the insurance company who's paying the money. There's a lot of mental gymnastics that people go through and moral gymnastics that people go through when they're sitting in a jury, but they have to understand what their job is. And it's the attorney's job, really, to make them understand what their responsibility as a juror is. Now, is that always going to work? No. But that is something that definitely happens, that we see these numbers sometimes come back because they feel like this family needs care. And our social system in general just really doesn't have what these people will now need.
And it's very interesting because in that particular colostomy case, my cross-examination, the plaintiff attorney pulled up all the pictures that the patient had with her colostomy, with the stool and the leakage, and they had a lot of good photographs, and that's what stuck in the jury's mind. As much as I was trying to explain, but let's remember, counselor, she did not need the colostomy. This was a judgment call made by the surgeon, which was not a breach in the standard of care to do a colostomy. That was okay, but she didn't need it. The surgeon had other options. So all those pictures you're showing, she actually didn't really need it. And I really thought I was bonding with the jury, but apparently I wasn't.
I think that the cases are instructive in, let's hit some points. The main one of the first case is they're going to ask you these emotional questions, and you should go into this deposition understanding how to answer tough questions like that and to never really concede to the hypotheticals that they might be giving you. In the next case, it really is about keeping your arguments. It's not a good look for anybody when there's a chart war. Everybody's going to lose because the jury isn't really that interested in exactly which physician is to blame. They're really most concerned with, is there blame? And in the last case, I think the point to take away from that is sometimes you just have no idea what a jury's going to do. And sometimes these verdicts are motivated by sympathy and a feeling that this family's going to need the money somehow. In other cases, it's driven by just this general feeling of dismay about the healthcare system and people not getting what they need from it. I do want to leave on the note that most often, still, at least 80 to 90% of the time in some states, the physician will win at trial, and you will absolutely improve your chances of that if you learn how to do this well. I make the point about everybody should know how to be a good defendant, and I think this shows why.
Yeah, no, absolutely. I mean, again, and even most cases never make it to trial. I mean, most cases, as you know, settle for some amount of money, but the ones that go to trial, correct. I mean, it's probably 87, almost 90% go for the physician.
Right. And maybe even the majority of them may actually be no pay cases. And then among what's left, those cases settle. And then this tiny little percentage, 8 to 10% of the time you go to trial. But just understand, if you're going to trial, it's usually because people believe in your care.
Right, absolutely. And I think, another last takeaway is none of us are alone in this battle, right? I mean, like I said in the beginning, I wish you were around when I had my first time, when I was sitting in the room and I was getting screamed and yelled at by something I thought I did right. So definitely, reaching out to other people that have gone through it. But again, even a lot of your own colleagues may or may not have gone through something like this. I mean, a lot of physicians get sued for sure, but we don't want to talk about it, right? It's too emotional to keep bringing it up. So having your service to help to take the emotion out of it, which is really what has to happen, is really helpful.
Thank you. I appreciate it. And I appreciate your help in that. I think that people are going to benefit from. We'll have to have you back sometime. We'll talk about some more cases just to show people, like, how do these things unfold? What can you be careful about? Still knowing that the outcome is not entirely in your hands, but knowing how to leverage what you got during the course of it. And it's not always the things that you think, right? A lot of times people, their instinct would be like, well, let me blame this other guy and that'll keep me out of it. And it's not what you think. It's not what you think.
Correct.
Well, thank you again. And I really, really appreciate your time.
Thank you so much.
All right, everybody. 2024 is a wrap. I will see you on the other side in January 2025 when I, again, would like you to know that I will have a big announcement for you, and I'm so excited. I hope you enjoyed our conversation with Dr. Cohen. I'm sure you learned a lot, and I will see you soon.